Good morning or good afternoon to everyone, depending on where you are joining us from. Welcome to today's online event featuring a panel discussion on Newcomer Healthcare. There is no one size fits all approach, presented by the National Newcomer Navigation Network. Before we begin today's webinar, I'd like to begin with an acknowledgement that N4 recognizes and values the continued connections and our ongoing relationships with our Indigenous peoples in Canada. They're traditional stewards of this great land, which has become the home to a diverse population of other peoples. N4 is hosted at CHIO, which is housed on the traditional land and unceded territory of the Algonquin Nation, and for that, we are thankful. My name is Mariah Maddock, and I am a project coordinator with the National Newcomer Navigation Network. I will be hosting and moderating today's panel discussion. My co-host, Natalie Graham, will be monitoring the question and answer box today. And I'm very pleased today to introduce to you today's speakers. And I'll start with Ms. Adele Owis. Adele is a graduate from the Social Service Worker program at Algonquin College. Currently, Adele is an outreach worker at CHIO, where she assists families in connecting with diagnostic services and therapies specific to their needs. Adele is also part of the coordinated service planning team, where she further assists families in need of additional support. Adele is currently attending the St. Paul University Certificate in Ethics and Contemporary Social Issues, Immigration and Integration program, where she collaborates with healthcare professionals across Canada and to further her understanding and ability to provide support to newcomer families. Welcome, Adele. And our next panelist today is Dr. Annalee Coakley. Dr. Coakley has dedicated her medical career to caring for marginalized and vulnerable patients, including refugees who often arrive in Canada dealing with myriad health issues after enduring unimaginable trauma. As the medical director of the Mosaic Refugee Clinic in Calgary, she not only provides compassionate care to new Canadians, but also advocates for her patients locally, nationally, and internationally. Dr. Coakley is a passionate advocate for programs that are crucial to her patients' health and well-being. In 2016, Dr. Coakley marshaled the community to welcome and care for the influx of Syrian refugees coming to Calgary, establishing satellite clinics and caring for those who arrive battling illness, injury, or trauma. More recently, over the course of 2017 and 2018, Dr. Coakley has helped welcome the Yazidi refugees to Calgary, providing healthcare to this highly traumatized population. Welcome, Dr. Coakley. Thanks for joining us. And our next panelist is Ms. Chantal Arsenault. Chantal is a primary healthcare nurse practitioner in Moncton, New Brunswick. She graduated with a bachelor's in nursing science from L'Université de Moncton in 2007 and obtained her master's in nursing in the nurse practitioner field in 2012. In 2015, she was mandated to develop a temporary clinic to offer healthcare screening for the large number of Syrian refugees arriving in their community. 5 years later, the clinic has become a permanent resource for refugees in her area and continues to grow and advocate for the needs of newcomers in New Brunswick. And I just want to give a really warm welcome to all of our panelists from different places across Canada, and thank you very much for joining us for today's panel discussion. And as a reminder, today's session is being recorded and will be uploaded with a transcript to our N4 platform within 24 to 48 hours following today's presentation. And should any technical issues arise during our webinar today, we will inform you with details on an alternate makeup session. And before we begin our panel discussion, I want to take a moment to introduce you to our platform features and help enhance your participation experience. Throughout today's session, we invite you to write your questions in the question and answer window. If you would like to direct your question to a specific panelist, please include their name at the start of your question. We will be monitoring these throughout the session, and we know that sometimes some of you might have the same question or be interested in hearing a particular response. So if there's a question in the Q&A window that you're particularly interested in, please use the thumbs up and that will upvote it so we can prioritize which question we ask to the panelists first. And our panelists today have no conflicts of interest to declare. So with that said, I'm going to jump right into today's panel discussion on Newcomer Healthcare. There is no one size fits all approach. And today we have an outreach worker, a physician, medical director, and nurse practitioner from Alberta, New Brunswick, and Ontario joining us. And I'll open up our discussion today with 2 to 3 introductory questions, and then we'll turn to the audience Q&A to guide the remainder of the hour that we have today. So our first question is, we know that after arriving in Canada and sometimes for several years following, newcomers experience challenges navigating the healthcare system. So please tell us what it is like for a newcomer to navigate the healthcare system. What are some of the sociocultural barriers a newcomer may encounter, and how do you mitigate these? And let's start with Dr. Coakley.
Sure, thank you, Mariah. So I think everyone in the audience works very closely with newcomers, and so I'll reiterate probably a lot of what you already know. So with a lot of my patient population are refugees, and so they've never planned on coming to Canada, so they haven't prepared, they've not learned English for the most part, and so the typical barriers that patients face have to do with the language barrier, because interpretation services are often not provided to newcomers. And so that's often the biggest barrier when accessing healthcare in Alberta. The other large barrier has to do with navigation of the physical environment as well as the systems. So both health and social systems, and you can't really separate the two because each impact the other. And so in terms of where our refugees come from, they often come from rural areas. They often have lived in refugee camps where everything was sort of one-stop shopping. They weren't allowed actually to leave the confines of the camp. And they've lived most of their lives in a rural area. So to suddenly be transported to Calgary, where we have a very complex physical environment that's very unfamiliar, and we have public transit, which in Calgary, frankly, isn't the best. And many of our health services are beyond access through public transportation. And so it's incredibly difficult for people to navigate the physical environment to get the care that they need. And then of course, our social systems are quite complex. So not only the governmental, but also the non-governmental. So, once their IFH support ends, needing to sign up for the provincial form of income support, having to report in through an online platform every month. It's incredibly challenging for people who don't understand the system and who don't speak the language, or who might not have the literacy required to complete various forms, et cetera. And then as well, just accessing NGO services is actually quite complex because there's many different providers, often very siloed. There's usually inclusion and exclusion criteria. And so it's very challenging for newcomers to figure that out. And so those are the greatest challenges. And so this is why they need a helping hand when they first come to Canada, not only to connect them to resources, but also to teach them how to connect to those resources. And so in Calgary, we've developed health navigators at our clinic to help mitigate those barriers and help people to connect to the resources that they need and the services that they need, and teach them how to do it for themselves moving forward.
Thank you very much, Annalee. And we'll move to Adele next. Adele's an outreach worker at CHEO in Ottawa, Ontario.
Thank you. Same as what Dr. Coakley was mentioning, is the language is definitely the biggest barrier as they arrive here in Canada. Here at CHEO, we do have interpreters readily available when needed, but also we do have options in the community for interpreters. A big barrier for families is understanding the multiple professionals that can be implicated in their health and their health care and their health circle, such as social workers, nurses, coordinators, the multiple specialists, It can be very confusing, and anyone that has been with a team, a healthcare team, can know whether you're a newcomer or a Canadian citizen. It can be very overwhelming. Not knowing and understanding each role as well can be daunting, and not knowing how they are helping you, how long they will be helping you for. So really, when you are going to be meeting with a newcomer family, is to identify yourself, to be able to let them know what services you're providing with them, and as well as if there is a time frame of how long you will be with the family, serving them and helping them. Understanding the coverage, as Dr. Coakley mentioned, the interim federal health, so the IFH, do provide many services and cover many services. However, there are exceptions. So knowing what those exceptions are, as well as to know that a lot of families don't know that it needs to be renewed. So that, I believe, is once a year needs to be renewed, if I'm not mistaken, until their court date for citizenship. The last barrier I think I want to discuss is the misconception of Canadian healthcare system. So understanding the referral process, the wait times. Many families will come to Canada having been told that doctors, nurses will contact them, or that services will begin immediately. Here in Ontario, and as well as other provinces here in Canada, there are wait times. And so there is a protocol of how to access, and there are ways to access the services they need. So to be really clear with the family and to set realistic expectations of when services will start and who's involved with their care.
Thank you so much, Adele. And let's move on to Chantal, nurse practitioner in Moncton, New Brunswick.
Thank you. So like my fellow panelists have mentioned, our biggest challenge and barrier to access and care for these clients is the language. I'd say over 95% of the clients that I see in my clinic do not speak either English or French, and those who do, maybe 1% are fluent enough to navigate somewhat the health system. We in New Brunswick do not have access to any professional interpreters in person anyway. We do have access to what's called the language line. So any communications that we have with our clients are through a speakerphone. And often the connection is poor. You will have different dialects and they don't understand each other, and you miss the benefit of having nonverbal communications to help confirm information. We can lose the interpreter. There can be long wait times to get an interpreter on the phone. So convincing, although in the clinic we have become accustomed to this service and we use it reluctantly as much as we can, convincing other specialists or hospital workers to use this is very difficult and met with a lot of resistance. So when we need to refer a client to, say, a specialist that doesn't speak their language, we have some that just refuse to see them unless they can bring someone with them that can interpret. And since they're new here, they don't have people that can interpret. They would not even be able to hire someone, seeing as it's not a service offered here. So that is a huge challenge for us that we fight with every day. And also, like was mentioned before, just understanding the system, knowing that you can't just show up to a dermatologist's office with a rash and expect to be seen. It has to come through a primary care provider and then be referred. And when I do that for a dermatologist, we're looking at a year's wait to be seen. It's not going to be immediate. And so when I mentioned there's a wait time, there's sure I'll wait a couple weeks. No, it's months to year for most issues that they're coming to see us. So they're not used to that. And they do expect to be seen right away. And understanding in the first year, they're going to have the IFH, and this may pay for services such as private physiotherapy or Tylenol. However, in the second year, they switched to our social development program with a different drug program, and now Tylenol is not covered. They need to pay for it. So then they question, well, why am I paying for this medication? I didn't used to pay for it. And we have to re-explain the service every time. And every time they see someone, they bring their whole list again, not knowing what each person's role is. So then you get multiple people involved sometimes in the same problem if there's not communication between the providers, which can cause just multiple confusions. We've had some children who saw 3 ENT specialists to have their tonsils removed, and by the time they saw the third one, he didn't have tonsils anymore. So it takes a lot of coordination, and the patients can easily get lost in the shuffle. So you have to be careful.
Thanks for sharing, Chantal. And it strikes me, despite being in different areas of Canada, you experience some really similar challenges, and then depending on the setting of where you are, those challenges can look very different. So our next question is going to build a little bit on that question that we've just discussed. And can you describe and provide examples of what some best practices in newcomer healthcare look like? And let's start with Adele.
So the main and primary one is listening to the family. So taking the time to listen, have the patience. There's going to be obviously that language barrier. There's going to be the interpreter there as well. So there's going to be a lot of downtime and waiting, but really take that time to listen and validate their feelings and emotions that they've been experiencing with all the changes that they've been enduring. Some families might be forced to leave some other families behind. They're coming with a history of violence, rape, abuse, war, refugee camps where there's lack of food, limited shelter. So taking that time to really sit down and being empathetic and showing them that you are there to help them will definitely be able to mitigate some of those fears that they have. As well as to educate yourself. So if you know that you're going to be meeting with a family from, for instance, Syria, it could be anywhere else, but educating yourself prior to seeing them. So look into where they're from, the culture, the religious backgrounds, and just see to be able to have a bit more cultural sensitivity towards them and be more prepared. As well as to help families be part of being their own experts within the medical system. So they know themselves best. They know here at CHEO, we work with families with parents for their children, but they know their children best. So getting them involved in all the medical services and being part of the team will also get their trust and really gain their trust with us. And then be prepared for or be aware of cultural mannerisms. Sometimes when you are starting as a provider with a new family, you might try to maybe say a joke or try to find something that's similar with your patients, but this can be seen or been taken differently. So it can be interpreted differently, and then it leads to confusion, and then there can be a breakdown in communication. So try keeping it really simple and very positive until you build that trust and that communication with the family. Connecting with services as well to provide that additional support. So of course, as we said, the language interpreters, settlement agencies, immigration services, anything that you can bring to the table for the family, the better would be. Not obviously adding so many people that it's bombarding the family, but at least having some options for the family within your organization, but as well as the community.
Thank you, Adele and Chantal.
I find that the most practical or helpful things that we have done is develop partnerships with as many people as we can. And ideally, we try to work as a one-stop shop because that is what's familiar to them, and being new in our area, they don't necessarily know how to access the different hospitals, the different departments in the hospitals, the multiple specialists in the office. So when we first started out, we definitely had that very one-stop shop possibility. So we had pediatricians that came to our clinic twice a month to see children, RCMP, parole officers, community workers would all come to our clinic to see the clients. And so the clients would then be familiar with our clinic, with the location, how to get there, who to see and ask questions to. So it made things a lot easier. Unfortunately, we've had to move into a smaller space recently, and we've lost some of that one-stop shop way of doing things. And we've noticed the difference with our clients. So we're trying to find ways to get that going again, because it was quite helpful. And developing those partnerships works kind of both ways. So we have a list of specialists that will see our clients that are used to working with newcomers that we use on a regular basis. And recently, just yesterday, I got a call from a pediatrician that we often refer clients to, who contacted me because he had been referred a patient from the emergency department who has sickle cell anemia and is going to need multiple tests, and they are currently applying to get refugee status but don't have it yet. So he contacted me to see, well, how can I help this patient? And so I'm going to see them this week so that we can try and figure something out for them in the meantime. But because we have that partnership and that open communication, and we do try to work as a team, we all trust each other and are willing to help out and have those open conversations. So that is a great help. But also being ready to wear multiple hats. I've called cell phone companies to help figure out bills, and I've talked to landlords, and I've filled out paperwork for housing and for drug programs. So being ready and open to wearing those multiple hats and helping where you can, and trying to find the right partners to do that with is key when working with this type of population.
Thanks for sharing, Chantal. And Dr. Coakley?
So similar to Chantal, so we too developed one-stop shopping so that people can learn to navigate the city, the system, and also learn some English. And then it's one-stop shopping for most services at our clinic. So again, a large multidisciplinary team, a lot of visiting specialists, for example. And then we have Language Line to help overcome the language barrier. One of the innovative practices that we've developed is we've created the role of a health navigator. And so this is an individual who is responsible for teaching patients about our health system and social system and how to operate independently within that system. And so it's everything from teaching them how to book a lab, for example, teaching them then how to go to the lab, booking, diagnostic imaging tests, and then teaching them how to get there on public transit. And so we do have that formalized role. Everybody, like Chantal's clinic, like everybody at our clinic does a little bit of the navigation. Like nobody can say, oh, navigation, it's not my problem. Often if you're sitting with a patient, no matter who you are, if you're the social worker, if you're the health navigator, if you're the doctor, I do spend time helping them overcome some of these navigational barriers. The other thing, the bane of my existence is actually accessing mental health resources, especially for our patients. And so to help with that, because in Calgary, it's an ever-changing environment, everything is so siloed. And so it's hard for me to navigate. And so it's incredibly difficult for my patients to navigate. And so here at the clinic, we applied for a grant for a mental health navigator team to help our patients navigate the different resources, because of course mental health encompasses a broad spectrum of services, everything from sort of help from the food bank to accessing psychiatric care. And so they help our patient navigate the mental health system. And so that's been one of our innovations at the clinic.
Thank you for sharing, Annalee, and noting that innovative practice. I can see that that's a question that's been asked by one of our participants. So thanks for touching on exactly what you meant by health navigator. And our next question, there's a lot of professionals attending this webinar today. So with all the constantly changing information, especially now during COVID-19, where do you turn to for resources, education, or credible information related to supporting navigators with navigating the health and social service systems? And I'll turn it over to Chantal first.
So this is always a challenge for us. We do have access, our organization, especially when we first received Syrians, the big wave of Syrian refugees about 5 years ago, there was a big effort in trying to get as much Arabic information as we could. And we had these different links to Up to Date or Micromedics who had patient handouts in different languages, and the IWK, which is the children's hospital in our neighboring province, had many things on their website as well that we tried to use, and we did use a lot of it, although we learned that sometimes if I read it in English and it seemed really good and appropriate in English and it was available in Arabic, I thought, great, I'll print it out, I'll hand it out. But at one point we did have an Arabic interpreter in our clinic, and they started reading the information we were handing out to patients and saying, this isn't what it says, and you're not giving the message that you are intending to give. So if I was seeing someone with a viral illness and trying to calm them down that, you know, it's a virus, it will pass, treat it conservatively and we'll follow up, but it will go away on its own. You don't need an antibiotic. And I would give out a handout on viral illness. And when read in Arabic, the emphasis was on possible complications like febrile seizures, death, sepsis. Well, that was going against the message I was trying to give the clients. So we modified a lot of it when we did have an Arabic interpreter and a Swahili interpreter with us. We modified some to accommodate our needs, but it was very difficult to find information to give to patients, and it remains a struggle. At the beginning, 5 years ago, there was lots of different conferences and you could network, and it was easier to do, although many of those efforts have died down. And often when we went to national things with people from different provinces, I found the information that was given was more of an ideal situation for provinces that had a lot more resources than our province had. You know, like I said, we don't even if we were willing to pay for an interpreter, that service doesn't exist in New Brunswick. So it wasn't always that helpful, although with the N4 community now, it's nice to have a place where different resources are available and can be shared. So instead of having to build everything on our own, it's a way to network. So I've started to look into that, and hopeful, and that so far what I've found is helpful. And I'm hoping to maybe be able to even share some of our resources that we've found. And I've also been doing the certificate program with St. Paul University, which gave a kind of a different perspective, I think, than most of the stuff that I was doing recently, where the focus is a little bit more on working on ourselves to become a better helper to the refugee instead of just learning on what the problem is. So I found that was a different perspective. But yeah, finding resources for clients is definitely always a challenge. And I like the idea of the N4 community kind of trying to put everything together, because that's the ideal.
That's great. Thanks for sharing that, Chantal. And Dr. Coakley.
Yeah, you can call me Annalee, please. So for me, the best information is found on the ground, right? Like at street level in the local environment. So when I'm trying to figure out how to help someone that I'm seeing, I look towards my partners and those relationships that I have with people working on the ground, because they are the best source of information that's up to date, that's practical, that our patients or clients can readily access. And especially in COVID times, it's never been more important to have those regular communications with partners on the ground, because everything seems to be changing week to week. So local partnerships, as Chantal was reviewing, like those partnerships are key. Because those partners are working on the front lines and know very quickly how things are changing in the local environment. So, and I feel like our partnerships within the community, so the broader community, really started to be forged during the Syrian surge, because so many Syrian refugees were resettled in Canada at one time. Like it really forced like the Calgary environment, all the different players. So whether it's school boards, police, resettlement agencies, health, it forced us to come together to develop a plan, a resettlement plan for our newcomers. And so I feel like this is carried forward. So, you know, with the Yazidi resettlement, there again, we all came together to discuss our challenges and how to best meet the needs of the Yazidi refugees. And now with COVID, we again have come together to discuss how can we best meet the needs of newcomers during this very challenging time. One of the barriers that I didn't mention, which has come to the fore, is really a digital divide as well. And so I think that bears mentioning because COVID has really highlighted that digital divide. So not, you know, because many of our refugees have had their schooling interrupted, many of them are very familiar with WhatsApp and Facebook, et cetera. But in terms of being able to access, you know, an AHS, you know, approved secure platform, it becomes very difficult to teach people how to link to that particular platform that we need in healthcare for data security and the privacy of individuals when relaying their health information. And so, and plus with large families, many people need to be online at the same time. And so just being able to afford a laptop for each member of the family, that's a huge barrier for most of our families. So that's just another barrier that we're still struggling with, but by working with our partners, we're able to help people access these different online resources. So I would say, for me, the biggest source of information are people working on the ground. So not only at our clinic, but our partners in the educational system and in the immigrant serving agencies as well.
Thanks for that, Annalee. And Adele.
So we here in Ottawa are very fortunate in many ways that we do have options in the community for families. So we do speak a lot to other agencies. So I do, as an outreach worker, I don't reach out to other agencies specifically. I work more with the one-on-one families and see what kind of services they need within our children's treatment center here at CHEO. But working as well with the coordinated service planning team, I see them being able to reach out to a lot of community services and educating themselves on what kind of services can be brought to the family and serve the family. But also like my Chantal, had mentioned, is the St. Paul's University. So I am also part of the program that I'm completing at St. Paul's, the Certificate of Ethics and Contemporary Social Issues, Immigration and Integration. I've been able to connect with professionals across Canada and different provinces, which really being able to communicate with them through this program, I found some support. and different perspectives as well from different professionals and what they're doing to support newcomers, and gives me as well as ideas just how to support them and explore different connections here in Ottawa. The course I've completed definitely broadened my understanding and provided resources as well. And of course the N4 program, so the National Newcomer Navigation Network, which I highly recommend. There's webinars, training, sessions, the latest news, blogs, real stories from newcomers and their experiences. And so it's a really good tool to utilize in your own practice.
Thanks for sharing, Adele and the other panelists. Definitely a lot of different places to look locally, nationally, provincially. So thanks for sharing. And anyone who is interested in more information on the online program that Adele and Chantal mentioned, or the resource toolkit, that can be found on our website at newcomernavigation.ca if anyone's interested. And now we'll turn it over to the audience question and answers period. So if you haven't already, please feel free to upvote the questions you're interested in hearing the answers to, and just a friendly reminder to if you want to direct a question to a specific panelist, to include their name at the start. So I'm just going to start right at the top with the first question. Dr. Coakley, what does it mean, in quotations, health navigators? Are these online platforms, organizations, or people? I think you might have clarified this during our discussion. Do you have anything to add?
Yeah, that it could be an individual role, or it could be an organization. Like many jurisdictions, like for example, Edmonton, they have a group or an organization called the Multicultural Health Brokers, and they essentially work as health navigators. And all across the world, health navigators have been proven to be effective and cost effective on top of that. And so I think it's a vital service that our health system hasn't really recognized, but I think it's coming. Like, I think it's our future. So it's both individual roles and organizations, health navigator organizations as well. Plus, I think it's also like a skill for any of us working with newcomers. I think that's part of our skill set. You will have to do some teaching on navigation, no matter who you're seeing or what specific work you're doing.
Okay, thank you. And our next question is coming from Amanda to Dr. Coakley. How do we best support families who have significant PTSD? I am not a physician who supports families to access services at CHEO, and often encounter families in distress due to war and conflict in their country of origin.
Well, I can't sugarcoat it. It's challenging. So I think, with PTSD and with other manifestations of trauma, I think there's a few things. Like, I tend to think of mental health and mental illness as being very like the management of that is very broad. So, it's like Maslow's hierarchy of needs. You first have to establish a sense of safety in the community, stable housing, financial security, food security, et cetera. Like, that needs to be met first. And then they need a sense of belonging, community, a social network. So that needs to happen. Then you can think about some basic psychological techniques like grounding and stabilization. Those types of psychological skills can be taught. And then I think you get into some more formalized psychological care like DBT, CBT, et cetera. And then at the last resort, like people with PTSD often, like with severe PTSD, often need some support of medication to help their symptoms. So generally they need help with, nightmares and flashbacks, and prazosin is a medicine that we use to treat those symptoms. Sleep is key. Like, that's what I work with people. Like, I generally in my medical practice, I address sleep first. So if sleep is disrupted because of nightmares, then I use prazosin. If sleep is disrupted because of other issues, I mean, there's a whole bunch of medications. Usually trazodone would be first line. And then of course there's some mood stabilizing medicine like SSRIs that can be used. But I think the bulk of the management is actually in those other basic needs. Those basic needs need to be met first before you often before you get into the formal psychological or psychiatric care.
Thank you. And our next question is open to all of the panelists from Amy. And Amy is asking, what are some ways universities, such as the Faculty of Medicine at the University of Ottawa, what are some ways they can support newcomers? What are some of the things they can do to support newcomers?
I'll take a go at this. We do have some partnerships with our local med school, and we have used some medical students who want to volunteer to come help us out in the clinic when possible. So we do utilize them in that service. We actually have some medical students who speak different languages. So when we can, we use them as well to help us interpret in some more difficult cases where the language line is not a great option. So we do try to partner up with them, and we have some nursing students as well that come do some hours in our clinic. The nurse practitioner students, the nurses students, and some medical students will come spend a day or two in our clinic just to see how it works to work with newcomers, because it is it's a different way of practicing. It's not your everyday thing that you see in your training. It is its own expertise. So they will come and spend some days so that when they do graduate, hopefully they are better equipped to see newcomers as well.
And I can also add, so I feel like the university, like we're a teaching site. I know University of Ottawa too, like with Kevin Potty's program, the medical students are quite key in meeting the needs of refugees in his particular program at the University of Ottawa, but I can't really speak to the specifics. Here in Calgary, we're also a teaching site for medical students and residents. And I feel like, I don't know in terms of how they can support refugees. I don't really know if in that learner role they're supporting refugees, but our hope is that we can build capacity within the greater system to care for refugees. Because my biggest dream would be to work myself out of a job. Like if each family physician, primary care physician had the skills and the time and access to language supports and all the supports that they need to be able to provide primary care to newcomers, I would be thrilled, but they don't at this time. And that has to do with a lot of systemic issues, like not being able to access language supports, for example, not being, our fee-for-service model is very poor. It's sort of a barrier to providing good comprehensive care, especially if something's going to take you a bit longer. So in terms of the university, so by presenting, like basically by having learners, having them understand what barriers newcomers face, teaching them how to work through an interpreter so it's less daunting, or they'd be more familiar with the service when later in their life they're encountering someone who doesn't speak the language. Like, these are my hopes, is just increasing general capacity within our mainstream health system in the care of newcomers. The other way that the university is helpful is actually through research. So if we're to enhance the care that newcomers receive when being resettled or settled in Canada, there needs to be policy change, and policy change usually doesn't happen without adequate evidence. And so with having researchers from the university investigate, for example, like the value of health navigators, you accumulate data, and then you can present that to the funders and decision makers, policy makers, and then hopefully persuade somebody in the future to provide services that actually support newcomers in their settlement journey, and help them access health services and other services shortly after their arrival in Canada. So I think that's the other area that they're helpful in.
Thank you, Chantal and Annalee. And our next question is from Corey. And Corey says, a barrier I come up against in my work coordinating home care supports for newcomers with disabilities/trauma is helping them access provincial funding. Can you speak to how newcomers, especially refugees, are supported in their journey to Canada? Specifically, I assume they have an immigration officer. Do you know if these workers have any training in navigating medical systems preemptively for these newcomers? Or does this fall to the newcomer to initiate/navigate with service providers in the community?
So I can take a stab at that. So it depends on who the newcomer is and what system they're coming through. So if you're an economic immigrant, you're on your own. There's no immigration officer for them. If you are a refugee, if you're coming through the refugee system, there's 3 different categories, right? So you could be a government-sponsored refugee. So government-sponsored refugees have a resettlement worker immediately upon their arrival in Canada. If you're a privately sponsored refugee, then you're supported by your private sponsor, whoever that is. And so it would be up to them to make those connections. If you're a refugee claimant, you're on your own. You're sort of the most disadvantaged of everyone. If you're a refugee claimant, you have to figure things out on your own. And it's usually through word of mouth that they get connected to our clinic, for example. In dealing with people with disabilities, like newcomers with disabilities, those newcomers with disabilities generally don't come through the immigration system because we exclude people with health needs through our economic immigration system. Refugees, so the government of Canada actually prioritizes people with health needs, including disabilities and trauma. And so there's a huge number of newly arrived refugees who have disabilities or mental health concerns. And then that is a struggle. Like I know in Alberta, for example, with our adults with developmental disabilities, intellectual disabilities, to apply for funding through the government of Alberta, you need to have an IQ test, but that's not publicly funded. And so it's a huge barrier. An IQ test costs usually a couple of thousands of dollars in Alberta. And so that's been a huge barrier that we've had to help people overcome. And we found workarounds at our clinic just because we have a donation account that the physicians contribute a portion of their pay. And so we have that donation account from which we can pay for IQ assessments that are done by my friend at cost at the clinic. But this is not a systemic solution. This is a little Band-Aid that I'm trying to put on just for my particular patients. So it's a huge struggle. But essentially, getting back to your first question, the government-sponsored refugees stay at a resettlement center for their first few weeks. From our clinic, we've got embedded nurses at the resettlement center, and they're linked directly to our clinic by them. And so we see them within their first 2 weeks of resettlement. I mean, it's COVID time, so they have to do two weeks of quarantine before we see them, but we're talking to them on the phone every day to check in. And then privately sponsored refugees have to be connected by their private sponsor, and refugee claimants, it's word of mouth. Anyway.
Thank you, Annalee. And Doa is asking, how can we get benefits from the high skills newcomers? So for example, a newcomer that might have a medical background from their home country and speak English and another language as a first language to help refugees?
I mean, that's a good idea. If you could get, like, we used to have a volunteer interpreter program where people like that, or, you know, there's lots of Canadian born people too who speak multiple languages. The challenge with that is I've found that volunteer systems don't tend to work. Like, people have to be paid for the work because it's quite time consuming. Like, I've found when we used to have, or CCIS, our resettlement partner, used to have a volunteer interpreter program, but it was too easy for people to not show up, to cancel last minute, and it wasn't very reliable. So that was a bit of an issue. But, you know, like, wouldn't that be great if we could have a reliable volunteer interpreter system that everyone could have access to?
Okay, and our next question is open to all of the panelists from Katia. It sounds like there are so many challenges when supporting the people with refugee status. Are you actively partnering with local settlement agencies for translations, interpretations, community referrals?
So me, absolutely. Like, I couldn't do my work without our resettlement partners, CCIS, as well as other partners as well. But CCIS is the Refugee Resettlement Agency in Calgary, and we're very, very close. And just to give you an example of the work that we do, so recently we did have an outbreak of COVID in one of our ethnocultural communities. So over 25% of the population in that community was affected by or infected by COVID. So the vast majority was affected. And so public health is a bit overwhelmed at this point. So they asked us to take over, like, all the swabbing, contact tracing, et cetera. So we did that, but we could only do that because of our partnership with CCIS. So because CCIS has the very, very close connections with the community, plus speaks the language, they were able to, like, we just got together, we did it together, CCIS Refugee Clinic, and we're able to swab 90% of the community and then do all the follow-up. And that would not have happened without our close partnership with CCIS in engaging the community and providing all those additional supports for people in isolation and quarantine, like the food support, the income support, emotional support, delivery of cough syrup and Tylenol and whatever they asked for. That would not have happened just from a health system point of view. That needed the support of the resettlement agency.
Okay, thank you. And I could see Adele and Chantal nodding their head when you were discussing your partnerships with settlement agencies. Do you have anything to add? Okay. So this hour has just flown by. There's a lot more questions here in the question and answer box. I do want to note to everyone who has their questions that any unanswered questions today will be moving to on the National Newcomer Navigation Network, the N4 platform. We'll be moving these into the meeting place, and our panelists have agreed to be open to responding to those questions for up to 10 days following the webinar. So if we haven't got to your question, we will get it to your question there in the meeting place. My co-host Natalie will put the link into the chat if you're interested in being a part of the conversation that takes place there. I do want to give the final word to each of our panelists today, and our final question for you is, if you have one piece of advice that you would give to professionals helping newcomers navigate the health system, what would that be and why? And we'll start with Adele.
I would first say to not underestimate them. They may be new to Canada, but to remember how much courage and strength it took them to leave their home, to come to an unknown country where they don't speak English, they don't speak French, they have limited to no support, and many cultural differences. So they have they could have left harsh circumstances, but they have the drive, the strength, and the willpower to seek a better life for themselves and their family. So don't underestimate their wanting the help that you can provide, as well as to, last thing is to really make sure that you are speaking to them at open conversations and making them part of the healthcare team, and listening to them, and they are the best person to talk to about what's going on with themselves. Or here at CHEO, we speak to the parents regarding their children. So they know their children's best, and to really get them involved in understanding what they need and what they feel they need for their family.
I think, Mariah, you're on mute.
Thank you. Thanks so much, Adele. And Chantal?
Yeah, I think that the best advice that I can suggest is to have an open mind and ask a lot of questions to whoever you can find to ask them to try and get that information. So whether it's asking your clients the questions to say, why are you doing this like this, or where did that idea come from? Why, where did you come from, what did you do before, has this happened before? And then partnering up with your local, whether it's the settlement agency, and asking them, what do you do when this situation happens? So having those partnerships and those different peoples that you can access is key.
Yeah, so I completely agree with Chantal and Adele. So one, that recognizing the resilience of your clients, that's critical. To meeting them where they're at. Somebody had asked a question about mental health in the chat box, and I completely agree. Like, you sort of have to Trojan horse mental health, and it's not just in our newcomers. I mean, this is for everybody in our society. There's no society where mental health, except maybe New York City, where it's not stigmatized. And so I usually only reflect back the words that they tell me. So however they're expressing their symptoms is what I use to, those are the same words. I use the same words to reflect back to them their symptoms and how to best manage those symptoms. And then, as Chantal was saying, it takes a village. So resettlement is a multi-pronged process. It's over the long term, and it takes the entire village. So looking at your own local environment and recognizing who your partners are in this journey, who's going to be walking this journey with the client over the next decade, and partnering with them and opening those lines of communication, because often they're, just in terms of the people that I care for example, the schools are critical with the children, because they're the people who will recognize the needs first. Because often if there's psychological distress, behavioral issues, etc., schools recognize that first, and the parents might recognize, behavioral or psychological issues, but they might not consider it a health concern to present to you as the physician or nurse. And so, having those open lines of communication with the schools so that they can then reach out to you, so that you can follow up with that particular individual. So anyway, taking a village, recognizing partners.
Thank you so much. Thank you so much. I just want to say a big thank you to our panelists today for just sharing all this information with us. This hour is certainly flown by today, and I just want to let everyone know we do see your questions. We will get to these into our meeting place. And I just want to take the opportunity to thank everyone for joining our webinar today. You're welcome to join us again for our upcoming events. And we also have a survey that will pop up in your browser following today's webinar. We really do value and appreciate your feedback. It actually helps us determine what topics we have webinars, where we look for resources, in the future. And if you missed any part of today's presentation, there will be a recording that will follow 24 to 48 hours following today's presentation. And once again, I just want to thank you so much for attending. We hope to see you at a future N4 event. Stay safe and happy holidays.